Our interview today is with Dr. David Fleming. Dr. Fleming is a former governor, chair of the board, a member of the Board of Regents, and former president of the American College of Physicians. David, can you tell me a little bit about where you were born and how you grew up?
Sure, Dan. First of all, thank you for this. It's great being with you and being able to share my story. I was actually born in Moberly, Missouri, which is about 40 miles north of where I live right now in Columbia, Missouri. And I was born and raised there in the community hospital where I actually ended up practicing after I completed my residency training at the University of Missouri. Pretty traditional, small town experience. I grew up and played sports and played in the band and did all kinds of activities, Boy Scouts and church groups, et cetera, et cetera. It was actually, in many ways, I consider it many of the best years of my life, just because of the formative experiences that I had, the folks that I had in my life at the time, not the least of which was my family, and the influence that they had on my life, but many others in my education and other activities that I did there as a youth. I left when I was 18, following graduation from high school, and came to the University of Missouri. At that time, I actually started in summer school that summer. My brother was here in school, and so I came down and joined him. And many years later, I returned to Moberly.
So your dad was a physician, if I recall correctly. Is that right?
Yes, my father was a physician in Moberly, and my great uncle, Tom Fleming, was also a physician. And both of them had a significant influence on both my choice of medicine as a profession, but also the way I practiced medicine. And of course, I returned to Moberly with I had always had that notion that I was going to do primary care after medical school. I wasn't sure what my specialty would be at the time, but I was actually thinking family medicine, but I was drawn to internal medicine, and I stayed as a generalist in my practice. But they had a very strong influence on my life, as well as my professional life. I like to, I sort of put it in terms of, which war each of them served in. My great uncle Tom Fleming was a physician with an artillery unit in World War I in France, and was on the front lines. Actually got gassed with mustard gas at one point. And my father was in World War II and was stationed in England on D-Day. They both served as physicians and served honorably. My war was sadly Vietnam, and although I didn't serve in country, I was in the reserves, and I was part of that process. But yeah, they were very much a part of my life then, and still are now. Yeah.
What kind of medicine did your dad practice? Was he an internist or a general practitioner, or?
He was an internist. He actually was. He did his residency was in pathology, and that was a time when residencies there weren't that many, and there weren't that many in residency when they were having them. Most physicians did general, except for surgery, of course, and anesthesiology did in OB. They tended to do sort of a general practice experience. Dr. Tom did internal medicine and cardiology, and Dad came back and practiced with him. And when I returned to Moberly, I Dr. Tom was still reading EKGs for the hospital, but was not clinically active otherwise. But I did join my father, and we practiced together for several years as we grew the practice. But Dad loved pathology, and actually was sort of called home during his residency at. He was in Kansas City. He was on Hospital Hill there in Kansas City, where he did his residency, and he came back, and they had their initial clinic downtown on Main Street, and a lot of what he learned from my uncle.
It must have been kind of unusual. I think in the 50s, pre-Medicare, about 80% of doctors in the United States were GPs, and residencies, as you know, were very poorly paid, and anybody who had ambitions to have a family couldn't really afford to be a resident. And of course, Medicare changed that. So
Exactly.
It's been unusual to have a couple of internists in a small town like Moberly.
It was, and the group he was in had were together for a long time. My uncle had partnered with a surgeon, a Dr. Streeter, and actually bought the building that Woodland Hospital was in. I don't think the building even exists anymore, but it was an old mansion, and they turned it into a hospital with an intensive care unit that he was instrumental in developing. And then, and that's when I came back in 1980. That was for at least several months while the new hospital was being built. I actually practiced in that building too. It was 1940s, 1950s vintage all the way. And
so what year did they turn the mansion into a hospital? When was that?
Oh, that was, I'm trying to think. Uncle Doc was that's my term that I use for Dr. Tom, Uncle Doc. He was fairly young in his practice, and he and Dr. Streeter, who was the surgeon, they bought it, and then they started bringing other physicians on board. And then Dad, he purchased it, I think after World War II, and he came back, and then he and Dr. Roulette, who was a general surgeon, a very good general surgeon, and they had an OBGYN, a pediatrician, all of whom were trained, residency trained, and then several general practitioners, core of 5 or 6. They had an anesthesiologist, a woman who did anesthesiology, and they had a very dynamic practice for many years. That grew from there. When I came back, a new hospital was being built, and a new clinic, and their clinics in the old hospital were in the basement. And I can remember going down there, and patients would sit out in the hall and to be seen. And then when their turn was come, somebody would stick their head out and call their name, and they'd go in and be seen, and then they'd walk out, and somebody else would walk in. So it was a lean and mean operation, but they made it work, and patients loved it. They had a cobalt machine. They bought a cobalt machine back in the day, and I remember my father, he went and got trained in how to do cobalt, and he for many years did cobalt treatments on patients with cancer.
Wow.
That was pretty primitive at the time, but it was that's what they did.
Yeah, that's impressive. I was interested in the mansion thing because the same thing happened in the town down the road from the farm I grew up on. A local doctor bought a house and basically turned, a 3-story house, and basically turned it into a small hospital. I think that the turning point must have been Hill-Burton. I think, the ability to create community hospitals from scratch must have been due to the Hill-Burton Act, and that must have been a major turning point, although I haven't really attempted to look into that in any depth. And of course, you've probably seen the papers, what's happening in rural Missouri.
Yeah, I
now.
think
all these small hospitals are closing.
Oh yeah,
So
they're closing. That's right. Now that was sort of the standard. I remember a lot of the communities around, the small communities around in north central Missouri around Moberly, like Macon, Missouri had a hospital, and it was a home that had been converted, and it was beautiful, all the with big columns and everything. And that was kind of what was done, because then critical care was not a thing. I mean, Dr. Tom had actually started a critical care unit to take care of his heart patients, and they had a single oscilloscope, single monitor oscilloscope where they can monitor the heart and kind of do vital signs, and that was about it. They had antibiotics, and they had adrenaline, and they had antihistamines and antibiotics and that, but the pharmacology had not really evolved as well, and everything was so sort of penicillin based. The cephalosporins were just coming into play. When we were in medical school, and the old K&G was the standard treatment at that time. So it was. I really watched an evolution in healthcare in that community, which was, I think, a snapshot of what was happening nationwide. And as hospitals became more and more refined and much more technologically driven, the new hospital that we moved into, Moberly Regional Hospital, is a beautiful hospital. It was about a 90-bed hospital at the time. It had a 6 or 8 bed intensive care unit, very well-trained staff, and it was just, and that was just over a few years that occurred, that we went from this sort of 1950s vintage hospital where patients oftentimes would come in and stay for weeks at a time. And oftentimes they stayed that period of time until they died. And because there were many elderly that would come in and stay in the hospital for long periods of time. And most of it was good nursing care. They would administer therapeutics and interventions and do surgery, of course, but it was the refinement of that as technology evolved was kind of amazing in terms of watching it. I remember the first summer I was there, I came back, I stayed on and did a chief residency year, which was not real popular by the folks who were wanting me to come back. But I told them, I said, I need that extra year, and I want to do the extra year. And it made a huge difference for me as it related to what I felt was my preparedness for going back to a community where I was not surrounded by, all the subspecialties and all the technology and the support that I was used to as a resident, where I could consult, phenomenal individuals to come in and help me care for patients. And I went up there, and it was me. And I looked around. There was nobody on my left and nobody on my right. Thank goodness we had excellent nursing. And I came into a situation in July, and everybody went on vacation. And that for about a month and a half, I was there literally by myself. And I think we had at least one code a week while we were there. And that was when, this is just an example of how challenged we were in that situation. When we would draw a blood gas in an emergent situation, and that's back when we would get blood gases during codes, I would ask for a blood gas, and they would draw the blood gas. They'd put it on ice. The highway patrol would come to the hospital, and he'd come in and get it, and he would then put it in his car, sitting next to him on his seat, and drive code 3 down to the medical center to get the blood gas analyzed. And about 40 minutes later,
the medical center, the local hospital, not Mizzou.
No, at Columbia.
Really?
He would drive 63, 40 miles, code 3, lights on, with the tube of with the syringe of blood on ice, and they would analyze it, and then they'd call and give the results of it. And after a couple of times, I realized that probably was not just cost effective, but it was certainly not standard of care. You know, you kind of need those results right away. So yeah, it was interesting. It was not long after that we got our own analysis technology there. So
To backtrack a bit, what year was it that your great uncle got his oscilloscope? Do you recall? Roughly when?
well, he had it when I went up there. I suspect it was in the probably late 60s,
Yeah. Okay.
maybe early 70s when he had it. He did a lot of, I mean, he did a lot of work. He worshiped Paul Dudley White. He bought everything that White wrote. I've got all his books, and he took notes voraciously in the margins of the pages, and I can see his handwriting all over that. And he developed that. I mean, he developed intensive care unit around the ability to do cardiac monitoring. You know, he was a master electrocardiographer. He really knew how to read EKGs and read them well, because that's all he had. I remember he had this handout of EKG instruction. And when I was up there, I did some EKG teaching for nursing staff and students and others. And I still have his notes and his handouts that he used, which was still very accurate. And that's what I used in my teaching. So
I'm curious. I was curious about it because historically the first coronary units weren't built in the United States till the early '60s, and same with pre-hospital care. So I was curious about his timing on that. Why was he so impressed with White? Did he spend time in Boston, or was it because White was Eisenhower's doctor?
I think he did his internship that's when back when he did 1 year of training when he went into medical school. Both of them were MU graduates here, and I think he had gone to some of his lectures because White did a lot. He was fairly prolific in not only what he wrote but in presentations that he did, and I think he did a lot of presentations probably at the AMA, and that's for ACP and a lot of the organized medicine that was out there. So I think he learned a lot of that through his involvement with AMA and others. But I don't think he traveled to Boston that much, but he certainly was very widely read.
Did you have siblings other than your brother?
I have the two brothers and a sister. I'm the youngest, and none of them went into medicine. They did very sundry other things, but my oldest brother, still alive, is 8 years older than I. Yeah.
What years were you in medical school?
I was there in 72 to 76, and residency 76 to 80.
And what was your class like? What was the makeup of your class like at Missouri?
We were a very unique class because we had a associate dean for education who was sort of ahead of his time. Mitch Rosenholz was his name, and he was interested in not just what we did in school, but what we did outside of school. It was pretty granola. I mean, we had a lot of folks that came from, were on a second career, who had done other things, who were very accomplished in other things. There was a deep focus on community medicine. And I remember one of the things that were interested in me was the fact that I was from a small rural community, and that I had plans to go back there. Many of our candidates tell us that they're interested in primary care and want to go to a small community and practice, and for various reasons they don't. But I was in a group of students who came in who were from Missouri, from small communities, from rural parts of the state, and most of us went and practiced in underserved areas, and it was very unique in that regard. And as a result, we had a lot of fun. You know, our class, we had a lot of folks in the class who were a little bit older, and had sort of been there and done that as it related to traditional schooling, and we're really interested in doing a lot more and learning a lot more. We had a lot of folks that went into psychiatry in my class, many who went into internal medicine, and many of whom stayed in general internal medicine. Two of my best friends, or one of them became a general internist, and but it actually ended up going mostly into research and qualitative research at Case Western. And then another one is from a small community, ended up being a cardiologist, but stayed here in Missouri as a cardiologist. So it's we had a good class.
What was the breakdown in gender and ethnicity, particularly as compared to now, would you say?
I'd say that there were more men than there are now. Now it's about 50-50. Actually, I guess our last class had more women than men in it. And ours, we may have had 25% women at that time. You know, and this, you realize this was sort of the Vietnam era, sort of in the tail end of Vietnam. And so we had several veterans. We had one man who had graduated from West Point and had come to our medical school, was going to stay in service, but he, instead of the armed services, the uniformed services medical school, he was with us. So, you know, another thing that was unique at the time about our class is we had several from other underserved populations. We had several African Americans, mostly men, that were in my class, and all of them have done very well. So, you know, it was an eclectic group, and with a lot of interest outside of the medical school. That's in as it relates not only to what they wanted to do professionally, but what they wanted to do to have fun.
So tell me a little bit about what it was like to be in school and to be a clerk, a medicine clerk. What was your clerkship like?
Clerkships were very traditional. You know, as a medical student, you know, we were just as with now, you know, during our third year, during clerkships, during the required ones, that was the tough year. You know, surgery, internal medicine were difficult. Family medicine was just beginning of sort of in its infancy, and they started taking residency sort of during my senior year. Jack Caldwell, actually an internist, who was associate dean at the time that I was there, was the one who started our family medicine program, and it subsequently has really thrived and done very, very well. It's one of the best in the country now. But that was not really at the time. It was just in its infancy. But you know, as I recall, as medical students, we were very involved in the care of patients, and you know, we did a lot of what we call scut work, but also we were sort of constantly there. We you know, took call, and we were there with the teams when during call. It varied on that, but I remember in OBGYN, we were in-house on call for deliveries. And so it was hard. It was very challenging, especially surgery. You know, you scrubbed in, and you stayed in the OR as long as they were in there. And if they went back to the OR and had a complication, you went back with them, and you stood there, and you were part of the process. And so it was very demanding, but it was good. when we transitioned into our fourth year, it was, I tell students that, fourth year of medical school is the best year of their life. They'll never be able to recreate the experience that they have by being, you're doing electives, you're traveling around doing interviews, much like our students do now. And they're in the process of choosing electives. I think that we were less focused at the time, as I recall, in medical school, on the knowing exactly what we're going to be doing at training. A lot of us really weren't quite sure what we wanted to do, what specialty we wanted to go for in residency. I actually started off interviewing in family medicine and switched over to internal medicine during my senior year, and ended up staying, mostly because of the leadership in the department. Is a strong department, and because that's what I wanted to do. I really enjoyed the rigorous thinking and challenges of what that had, what that offered. It seems like many folks they already know what subspecialty they're going to be doing. They know they're going to be an interventional radiologist, or they want to be, they want to do derm path, or they want to, they've already got they already have it well lined out as to where they're going to go and what they want to do and how they're going to do it. And I think it was less, I don't say it was murky, but we weren't quite as locked in as perhaps people are now. And it was during that's sort of came about during the fourth year. And I'm not sure that it was any better, but certainly I felt it gave me an opportunity to open my mind and my heart to other things while I was still there, being able to taste it and do it, and to help sort of influence what I was about to do in the years to come.
Why do you think that is? Why do you think students now are so predetermined as compared to back then?
Yeah, that's a good question. I really think that medicine as a profession has become much more, in many ways, predetermined, and those that are going into it almost in a self-defensive mode. I think student debt and going in with the financial burdens that a lot of students carry now, that is much more than I think we had when I was in school. I think that may have something to do with it, but I think also individuals want to. I think they feel like if they don't grab that brass ring now, that it's not going to be there for them. They don't want to get into a situation where 5 or 10 years down the road they're exhausted and burned out, and they're seeing that. And many physicians that are in practice right now, certainly many physicians that are doing what I did. I was a very traditional internist. I was on call every third or fourth night, and that usually meant more times than not I was in the hospital after hours, seeing patients in the ED and getting them admitted, or seeing somebody who's crashing, burning on the ward. But I'd go in early, I'd make rounds. I did my own critical care. I'd get over to clinic between 9 and 10, and I'd start clinic, and I'd see 20 or 25 patients in the clinic. And sometimes I would go back midday or in the evenings, and I would see selectively patients that I would need to see on rounds again in the day. It was very challenging. We didn't have hospitalists. We didn't have ambulists like we have now. And I think now there's a big concern that we're going to get hammered, and that we're going to get into a situation where almost half or more physicians are employed now, and it's all about contract negotiation, which didn't exist back then. In in my day, and when I started practice, we didn't work for anyone. We might get a piece, we might get a little extra money to do certain things for the hospital, like, utilization review or whatever, but or to make an administrative role. But for the most part, you took care of your own practice, and you were responsible for yourself as it relates to your business plan and how whether you're going to be successful or not. I think we're really steering away from that now. We don't see that, and I think individuals that are going into medicine now, plus they have much access to so much more information, they're much better prepared in knowing what's out there and knowing what's available. I think they're much more sophisticated now with the glut of information that they can have access to become knowledgeable about what is available, and they start getting competitive for the positions that they want very early as they pursue them. So I think it's in a way I think it's good that there is a greater sophistication in how knowledge is shared and how students can prepare themselves for training and then for practice. But on the other hand, I think that some of the glow is lost in the idealism of what it is to go into a profession like this. And we think, there's a tendency to get pulled away from the ideals of what it is to be a physician at the bedside, and to embrace that as what you want to do, rather than trying to protect yourself as you move into practice, where you may feel like you're going to be more vulnerable.
So I think that indebtedness probably has something to do with it. Do you recall offhand what your tuition was at Mizzou?
I know as an undergraduate, my tuition was like $250. I mean, I was an in-state student, and it was nothing. But I actually can't remember exactly what my tuition was in medical school, but it was a few $1,000s. It was certainly not anything close to what it is now.
I was 2 years earlier.
And yes, there were student loans.
Yeah, I was 2 years earlier than you, and if I had stayed in state at Nebraska, it would have cost me $700 a year in 1970, and Duke was $2,200 a year, which I couldn't have afforded except for scholarships. And you were right on the cusp of a couple of things. One was that there were 8 women in my class of 108. By the time I graduated, the incoming class was 44% women. And you were riding that wave just a little bit later. And then the other thing that happened, and this probably also had an impact on you, is that the tuition at Duke doubled from 1970 to 1974 because Caspar Weinberger, who was secretary of what was then called HEW, withdrew the federal grants for medical education. It used to be that there were federal grants. The feds had poured a bunch of money into increasing medical school sizes and increasing the number of medical schools in the 1960s. And in the second Nixon administration, Weinberger withdrew that money, and it just took off from there. So I think that's had a huge impact, although it doesn't get discussed as much as it might. And I think it's going to be really interesting to see what happens with the experiments at NYU and at the Vagelos College of Medicine at Columbia, in terms of the no student debt at graduation. My class, I graduated with no student debt despite going to a private medical school. And we did it by living very badly. I mean, we were very poor. We lived, in, substandard housing. Kids now just borrow more money and live well. So anyway, so it's an interesting thing. I was curious to know a little bit more about what you considered scut. What kind of scut work did you have to do as a clerk?
Well, when I was in training, the residents were expected to do everything, mainly the first year residents who had primary responsibility for the patients. And I'm talking about doing their EKGs when they got admitted and subsequent ones that they might need. You went and got the EKG machine. That's what the little suction cups, and you do the EKG, you draw the blood and you would drop it off at the lab. You would transport the patient down to radiology to get things done. I mean, they had some courier services and phlebotomy services and all that, but the understanding was that the mainly the intern, the R1, the first year resident, would do all of that. Because if you didn't, there was a big, huge delay in actually getting the information. So, we'd walk in and see our patient. When I'd walk in to see a new admission, I would have my EKG machine. I'd have all my stuff to do my examination, but EKG machine, I'd have my all my stuff to draw blood and get a urinalysis. And we often did our own UAs and did the blood counts as well. Our chair was Chuck Mingle was a phenomenal guy, Duke trained, Hopkins and Duke trained, and he was a hematologist, and he wanted all of us to know what blood cells look like. So we did our own blood counts, and we'd get extra slides, and slides had to be in the chart. I mean, there was a lot required of training other than reading and thinking and being involved in interventions, doing interventions, it helped me learn how to be efficient, and helped me learn how to do stuff, and how to get things done more quickly than might get done otherwise. And I still sort of have that notion that if something needs to be done, go do it myself. Don't wait for somebody else to come and do it, because it'll usually be delayed or not done the way I like it done. So that has gotten me into trouble a few times at home and elsewhere when I kind of step in and try to take charge of stuff. But I feel like if it's got to be done, you do it, and don't wait.
I was going to ask, did you run bacterial logic stains as well?
Yeah, we did them on gram stains, mainly in AFB, gram stains and AFB, and we had the labs on each ward had its own lab and set up to be able to do that. So I do, when I do an LP, I do my own stains and look at them. I didn't always know what I was looking at necessarily, but I did them, and AFBs, wet preps, all of that. So
it's interesting, those labs are all gone, and the pathologists who were responsible for supplying the stains and so on say it's all about quality control, but it seems suspiciously related to the availability of Medicare funding, that made all those things happen.
Yeah.
So
I remember when I couldn't. I used to carry a little tube of Hemocult developer, and I did a Hemocult on every patient with the rectal exam, and I would test the stool, and I'd carry that. That was just part of what I did. I remember later, as an attending, when I would do my exam on a patient, I'd say, okay, where are the strips? I want to do a Hemocult. And they said, you can't, that's no longer available. You can't do that. You have to order it, and which get charged some astronomical, fee for somebody coming in and putting it on the strip and then putting the developer on there. Yeah, I think the business of medicine has taken all that over.
It has. So tell me a little bit about your training program and your training and whether you think it's different from the way it's done now.
Yeah, I think it's different, certainly with the work hour restrictions and the limitations we have now in the kind of demands that can be placed on residents. I personally view that as a good thing if it's done well and if it's balanced. We certainly want to have, the whole purpose of residency training is to take care of patients and to take care of patients with mentors who have the wisdom and knowledge that to teach at the bedside and to where you can learn those skills at the bedside. As when I became a mentor, when I became an attending, the best part of all of that was being at the bedside. And when it's late or when it's after hours or when a resident's been on call and they have to leave at a certain hour, and I'm there with a patient and there's a teaching moment and the resident can't be there because he has to go home, that you just, okay, that's a lost opportunity that is there. But I think that has to be balanced. I for one was absolutely exhausted after my first year residency. I mean, it took me several months actually to kind of recover and regain the fire in the belly that I had going in, because I was just physically and emotionally drained. I basically lived in the hospital. Whether you're on pre-call, on call or post-call, you still got a lot of sick patients to take care of, and you're the one that has to get it done if you want to get the patient moving through the process and discharged safely home. It took a while, and I think that now things are structured with the where the hospitalists are available as attendings really pretty much all the time to help in the care of the patients. Whereas when I was there, we didn't have hospitalists. We had subspecialists who would rotate on service, and you might have a hematologist this month, and next month you may have an oncologist, and the month after that a rheumatologist, and you're talking about hematology, oncology, or rheumatology when you're making rounds, because that's what the attendings would know about and they would do. And they didn't really know what if the hematologist didn't know what the EKG necessarily looked like, he would say, you get a cardiology consult, and which is what we would do. But we really learned to be self-sufficient in learning how to tap into those kind of specialists that are there. And I think now having hospitalists as attendings, which are basically generalists, which is what I was, who can help sort of guide the process there and available in the swamps at the bedside, I think is an enrichment if you've got good hospitalists, and they're there not just to to work there 2 weeks and then rotate off, but they're there actually to teach and to mentor and to be available and to help the residents, which ours are, and I think most are in systems that are good. And so I think in general I think it's good. I think it's better. The residents don't seem as exhausted. I don't think that the work hour restrictions and the other kinds of fine tuning and restrictions to improve the quality of life of residents has had necessarily that much of a deleterious effect. What I'm finding is that our residents, when they're getting ready to go in whatever direction they're going in, are superb. And I think it's true of most programs. And again, they're all of them they're all subspecializing. It's rare to find one who wants to go into general internal medicine and who wants to go back to the community and to do what I did. But there's still a few out there, that want to do that, and I love them all. I think that's what we need. My hope and prayer in the years to come is that we can find a way for programs to really make, and that society can really make that specialty something that is good. that young folks in internal medicine want to pursue.
So I assume you did all your own procedures, thoracenteses, spinal taps, paracenteses, that sort of thing. Is that still the case? Do the residents still do their procedures, or do they get the radiologist to do them, or does the attending hospitalist do them?
Yeah, they don't. I don't think they do bone marrow. I did a ton of bone marrows when I was an intern. I stopped doing bone marrows when I went into practice because I felt that as an invasive procedure was something that we really need somebody who does them all the time to do them. So if we and oftentimes our pathologist actually would do the bone marrow. But I did those. I did central lines, art lines, all the stuff that we were trained to do. I think now the residents aren't having the availability to do those kinds of procedures like they were doing them before. If they go into fellowship, they do them. They do central lines and all of that. But I don't think they're doing bone marrows. They may do arterial sticks and drug acids, but now they've got other folks to do it. And I think it's probably okay. I think if you're going to be in that specialty area, then you need to learn those particular interventions. But I think that's probably okay from the patient standpoint. Now that I've been a patient, I appreciate having somebody with skills coming in and doing those procedures.
I was curious to know your thoughts about that. I had quite negative feelings as the procedures started to migrate to the subspecialists, and then I watched what happened out in the community, and in the community, at least in an urban area, the general internists aren't doing those procedures anyway, even if they're trained for them, in part because of time management, and they refer them to the subspecialists. I don't know whether that's the case in a place like Moberly or not, whether the general internists still do their own procedures or not.
Well, we do, and that's mainly because we didn't, for many years, we did not have a cardiologist at hand to come in and do, central lines. We didn't, and so I continued to do my own procedures. I didn't do bone marrows, but I did the others, and like for chest tubes and for those kind of things, we had some very good general surgeons who would do those. So I was selective about it. I did what I felt I could do and do well, and I let a lot of the other stuff go.
So you
did a ton of treadmills.
Oh, did you? Yeah.
Mm-hmm.
So I wanted to spend a few minutes talking about your interesting mid-career change of direction, if it were. Maybe you could talk a little bit about how you got interested in ethics and ended up going to Washington and coming back and joining the full-time faculty after private practice.
Sure. Yeah. I really started getting interested in bioethics during my chief residency year. And a lot of this, as with many, I found out that I didn't take care of dying patients very well. And I wasn't surrounded by people who really knew how to take care of dying patients. And that we still didn't communicate with our patients, even though we were with them all the time. Probably the communication was not as good, and the shared decision-making process was not so good. And so there were always these sort of lingering questions and issues about that. And when I was chief resident, my mentor at the time, who was also chief of medical services, Dan Winship, I was at the VA, and he was chief of medical services at the VA, had actually spent a year with Ed Pellegrino when Ed was at Yale, and we spent a lot of time. His and my office were right next to each other. We saw each other every day. We had many long discussions over lunch and whatever about these issues. And when I was there very early after I had gone into practice, he encouraged me to do sort of an immersion week in bioethics at Georgetown. At the Kennedy Institute, they had introduction to bioethics, which is basically going and reading the Principles in Bioethics, the Beecham and Childress text, which is in its 4th edition at that time. And you go and you live on campus and you read the text and you go to lectures and discussion groups and you sort of an immersion process there. And that's really where I got hooked on it. I wanted to do more. Now I didn't, I other than being involved in discussion groups and interest groups and ethics committees, I didn't really do much more with it at the time because I just didn't have it. And I didn't have a background in philosophy or ethics from my previous schooling. But really it was when I was actually back on faculty at the dean had asked me to come back on faculty because he wanted more community physicians involved in the teaching process. And so I had joined the faculty again in 1995 while still in practice in Moberly. And I was actually vice chair of the department in 1998. There was a new chair had come in and they'd asked me to be vice chair. And I was trying to do my practice in Moberly while vice chair of the department. And I was coming down and being part-time. And it was just kind of disjointed. And he just kind of wasn't doing it. And so I just picked up the phone and I called Ed Pellegrino and I said, I'm kind of at a point where I feel like I need to be doing something. It's something I'm interested in, and what I had in mind was maybe doing taking either leave of absence or doing a locum, or not a locum, but going and doing an immersion process maybe for a year or so, and just to see what he had. And he invited me to come out and look at what they had, this new fellowship that they had just started. And I went out and it was an HHS funded 2-year fellowship on campus at the newly founded Center for Clinical Bioethics. And he said, come on out, let's look at it. And I applied for it and got accepted. And so I went and it was a life changer for me. And when I came back, they had recruited a couple of physicians to come up and take my practice. And I felt that I could, that's a direction that I was not ready to re-engage in at that time, because I really wanted to start doing more on the academic side and as it related to teaching and in bioethics. So I came back and on faculty and stayed here at the university, and we developed the center and it grew from there.
Then how did your academic career progress subsequent to that?
Well, it's like anything. You oftentimes don't plan these things, but one thing led to another. I was blessed to have a dean and a vice chancellor for health affairs when I came back that saw the value in what I had to offer in starting a bioethics initiative here at the University of Missouri, which we did not have. We had another mentor of mine and a good friend of mine, Bill Bondison, who was on the philosophy, who was a philosopher department and had been here for many, many years, and sort of a beloved individual who embraced starting a bioethics program here. And he really was one that opened a lot of doors through introductions. I had leadership that gave me the time to do it and to grow it. And I was able to, get more people interested, and it just grew from there. I'm still not quite sure how I became. I know how the center grew and developed. One day, many years back, that the dean at the time asked if I would be interested in taking the chair of medicine. They were in transition at the time, and so I said sure, I could do that as long as I could continue to do my bioethics work. And so it's one thing kind of leads to another, and when I talk to people about this, and I say, oftentimes things are not planned, but these opportunities come about, and you have to make a decision where you're going to reach out and try to grab that brass ring that's going by. And if you decide not to, because there's other things that are important to you that you want to do, then so be it, and that's okay. But if you don't grab for it, you're not going to get it. And sometimes it works out and sometimes it doesn't. But as long as you're confident and you have an open mind to change, then you might think about it. And I've done that a few times, and it's pretty much worked out for me, because I've had folks that have been supportive and that are telling me it can happen. Now, oftentimes the folks that are supporting you and saying you're doing a good job and we want you to keep doing it, and here we're going to give you the time to do it and a little bit of resource to do it. Eventually those folks aren't around, and there are other folks that come in that they may have a different idea as to what's important. But still, if it's important, you do it, and if you feel good about it, you continue to do it. And if it suddenly becomes unavailable, then you obviously have to stop doing it. You need to go in a different direction. But so far for me, it's worked out well. I had 7 good years as chair, and the time comes when it's time to move on. And for me, it was time to stop being full-time, and I wanted to do a little bit more with my life other than be in the chair's office and doing other things. So I transitioned to emeritus status and living the dream right now. So I'm still doing my bioethics, so it's the perfect combination.
So to pivot a little bit, can you talk a little bit about your career first with ASIM and then with the college?
Yeah, there's another, sequence of events that was unplanned, and where it just happened. Alan Nelson, who was a past president of AMA, and who was he's an endocrinologist actually, but was the executive director for the American Society of Internal Medicine, invited me to become one of the trustees, and that occurred as a result of. Now let's just step back. The ASIM developed as a spinoff from ACP, American College of Physicians, as an organization that was interested in socioeconomic and policy issues in healthcare, and interested in things like, professional distribution and how we train our residents, and how healthcare is reimbursed, and what are the social determinants of health, and discussing those situations rather than the more academic kinds of discussions that ACP had at that time. This is before the merger had occurred, and when I went into practice, one of my mentors here again is the impact of mentors, called me up one day and said, "Well, David, congratulations." I said, "Well, thank you." This is John Winokur, who's an endocrinologist here. And I said, "Thank you. What about?" He said, "Well, you're now on the council for the Missouri Society of Internal Medicine." I said, "Really? Well, that's great. What's that?" I had no idea what it was, because I'd always done ACP. I'd been on a member of AMA, but I knew about ACP because that's where I was in internal medicine as a resident. And I joined the council, and I kind of liked what they were doing. These are some good people in mostly Kansas City and St. Louis, but also in outlying areas in the state, who looked like me and talked like me and had the same values. And, and when I say look like me and talk like me, they were mostly white males. Very few women and very few individuals of color, but yet these were because, but the demographic of those who were practicing in rural Missouri were people that looked like me. But I really like those conversations. I ultimately sort of moved up. I became president of Missouri Society of Internal Medicine. And I was there sort of during that transition that occurred. As a result of my involvement with MSIM, I became involved in American Society of Internal Medicine, obviously, and that's where I got to know the leadership there. And that's when Alan Nelson contacted me, and this was about 2 years before the merger with ACP. And so he invited me to come in, and I was actually one of the last two trustees that came on the board of trustees for ASIM, just as the discussions about merger were occurring. And as you know, Alan was very important in making that happen with ACP and ASIM. So, with Warren Levenger and others, I was thrown into the discussion about that blending process. And it was right, I think, after my presidency year that the merger occurred, and that's when I started getting involved with ACP, actually. And I was on the council, and after several years, as you know, I became governor. And it was when I came back for a visit. I was actually in DC, and I was looking at coming back, and I was going around and visiting folks in the department. And this was in 2000, I think, or no, 1999 perhaps. In 2000, when I went in and I talked to Sarah Walker, who, and I think she had just finished her presidency year, if I remember correctly. And I walked into her office and say hi to her, and she looked up and said, "Hey, David, hey, how you doing? How'd you like to be governor for the chapter? And put your name in for governor." I hadn't even come back yet. And she, Ann Winkler was the governor at the time, and Ann had talked to me and said, you might want to think about this in the not too distant future. So I threw my hat in the ring for governor, and was blessed to be selected for that by our membership, and then got into that marvelous experience of the Board of Governors, which is phenomenal, as you are now experiencing. And I got tapped to put my name in for chair of the Board of Governors, and by some miracle I got it, and the rest is history. I got on the Board of Trustees and moved up. It's a phenomenal, energetic process, as you know. And what I found is that you just, you stay nimble, you stay part of the conversation, you try to listen well, and offer substantive comment when there's substantive comment to make. And which means that quite often I spent most of my time listening rather than trying to give comment, because much of what was talked about was very complicated. And I figured I was surrounded by people that were a lot smarter than me and knew a lot more about what was being talked about. But I would offer my ideas when that time came, and it all evolved. The dominoes fell, and they fell in the right direction for me, and I had a wonderful ride.
So I know you, and I know your wife's a physician as well. What about your children?
Mm-hmm. No, my daughter is a PA, and is not practicing right now, but she practiced for several years. She's in St. Louis, and I have we have a son, and he's not in healthcare at all. Yeah, I was really sort of the last in my lineage, you know, following my father. I was really the last physician. None of my nieces and nephews or kids are interested in it. I don't think that the sort of the thrill of that is there like it used to be for young folks. I think that there's, you know, first of all, there are a lot of other interesting things to do in life, and I think that, you know, folks realize that it's a lot of hard work, and it takes a major commitment to really do it and do it well.
You have young people coming to you and asking for your advice now about whether to go into medicine?
Yeah, anybody who comes to me about medicine asked me if I would do it again. I said, without a doubt, I would do it again. It's been a phenomenal experience. It has shown me what my capacity is, and it has certainly shown me what my limitations are. And I learn that every day. I learn what I have grown to become very comfortable at what I feel I'm good at. And I have, you know, I've been around long enough that I've got some thoughts and ideas as to what might work and what might not work in certain situations. And I try not to impose that very often, but when I'm asked, I offer that. But I have absolutely no regrets, and I would not do it. I would not do it differently. Somehow, I've been able to have a dual career here, where I had an incredible practice for 20 years in the community that I love, and I followed through in doing what I said I was going to do. I wanted to do primary care. I wanted to follow in the footsteps of my great uncle and my father, and I wanted to practice in Mobley because it sounds corny, but I felt I needed to give back to that community that gave me so much, and I did. You know, I felt very good about it. I had a dynamic, very wholesome practice, but what I've had since then has been amazing as well. It's been different. The clinical piece has been quite different from my community practice, and I knew I would never be able to recreate that. But I've had the opportunity to teach, to mentor, to have some hopefully positive influence on young minds that are coming up, that are scary, brilliant people in terms of what they're doing. And I continue to have that some involvement in many of them that are coming through now. I love to teach. I've always loved to teach, and that it took me a while to really learn how to do that, but I had the opportunity to develop those skills. I've had the opportunity to contribute in an academic way to scholarship and to research and to sort of contributing to the knowledge base that's out there. And to be able to walk side by side with giants that I consider in medicine, people like Ed Pellegrino, of course, and Dan Winship and Chuck Mengel, and you know, my father and my great uncle and others who have been revered and highly regarded, and to be able to learn from them and to you know, to have that influence the trajectory that I took has been an incredible blessing, and that's a gift that I couldn't have gotten had I not reached out for that brass ring and reached out for those other brass rings that came along. When those doors open, the doors don't open, they don't stay open very long, but if you step through them and you take that opportunity, it oftentimes works out very, very well. So I'm a fan, and it's not easy, and I'm very quick to insert that when young folks ask me about that, and they don't ask me very often anymore, but they do ask at times. And I'll say, you know, it's challenging, it's hard. You're going to trip and fall from time to time, and you may fall flat on your face from time to time. But the successes are glorious, and you know, the impact that you have on the lives of other human beings, matchless. There's nothing like it, and but you got to be willing to make some sacrifice. You got to be willing to step into it, and to be fearless, and just not be afraid and go for it.
So this will be my last question. Time to bring this to an end. I would say that our efforts to increase and place physicians in the primary care pipeline have been manifestly a failure. I think it's shown in the independent licensure laws that are springing up around the country for PAs and NPs and nurse doctors, and in Missouri, these assistant physicians. Yep. If you were czar, if you were healthcare czar, or if you could tell Biden or a czar or whoever how to increase the primary care output and placement in the United States, what would you tell them?
Yeah, well, I'll be honest with you. I'm not sure it's a resolvable situation. I'll just say that. I don't think there's a magic solution to getting young folks to say, "Hey, I want to be a general internist in Moberly, Missouri, where I'm going to get my butt kicked for 10 to 12 hours a day, 7 days a week," and recognizing that it's glorious and it's wonderful and it's professional and fulfilling, and you're really contributing. But there is a there has to be something that's there. The notion of self-sacrifice is passé anymore. The notion of sort of giving back and contributing and doing good for humanity, as corny as it sounds, has been very real, and for many it is very real. But you can't really incentivize that. You can't really incentivize for that. And I think that healthcare, medicine, and the other professions that are seeking salary increases and all, and through their contracts, through their contractual negotiations with whomever they're going to be working for, it's all transactional anymore. It's all transactional. I think that I don't think we can do it. Healthcare now is I hate to do doom and gloom, but it's healthcare is very much a business, and individuals that are going into healthcare are transactional in what they're needing and what they're seeking for self-preservation, and I understand why, because that's how it's evolved. I think we could certainly incentivize monetarily in making it more lucrative and more financially doable to go into practice in communities. Is it all about the loans? I think that has some impact, but I think if we paid off all the loans, I'm not sure that there would be a major shift back doing primary care and going to rural Missouri and practicing. There has to be, to do that, to go anywhere in practice medicine, it's got to be about something more than the money. It's got to be something about it's got to be more than what's in it for me, and for my family. Knowing how important family is, and knowing how important it is that we care for our family and that we are able to support them. We get paid a lot. And I've said this many times that I think physicians are overpaid. I think we get paid too much. And I know you're going to think I'm a communist here, but we get paid. We do quite well in primary care. We get paid quite well. We have a good income. We are well above everybody else in this country, except for the oligarchs. And so I think it just until we can shift away and get back to what it is within the profession and what it's about as a healthcare professional, and what are the non-monetary rewards that relate to, giving of yourself for the good of your community and the good of your patients. It's not there. And that's not to say that those who are in medicine, who are contractual and transactional, don't have their interest of their patients primarily in mind. But I think that's going to be it. Now, if we were all employees of our healthcare system, like they are in England and in Canada, and elsewhere, where those salary structures are preset, where everybody's on pretty much a level playing field, and there are only certain numbers of individuals that could go into certain specialties, and most are going in, our GPs are going into primary care. I think we'd be having a different discussion right now. Most physicians in the universal healthcare systems, where there is a universal payer that covers all of the expenses of healthcare and pays the salaries of their physicians, most of the physicians are pretty satisfied with that. They're pretty happy with that. I think there's no way we're going to be able to transition to that. I mean, our country is not going to do that. That would have had to have happened a long time ago, I think, if we were going to be successful at it. So I think that, we need to continue to find ways for young folks to choose community practice to where they feel that they're not under threat of either being burned out or worked to death, and where it's financially viable for them to do that. But while that's going to be very challenging when we've got such fellowships that are making $500,000, $600,000, $700,000 coming out of fellowship, guaranteed to do what they do, and they're not having to work 12 hours a day, compared to primary care that's getting much, much less than that, and they are working 8 to 12 to 10 to 12 hours a day, and still trying to take care of their family. That is an unlevel playing field that cannot be played on effectively. And so I think it's still going to be transactional, and we're going to, the only way we're going to get people out there is by contracting and offering incentives for them to do that. So that was a very murky, probably unsatisfactory response to that question, but I tend to be an optimist, but in this particular question, I tend to be a pessimist.
All right, I think that brings our interview to an end. I appreciate you taking the time to do this.